Now, moving on to the discussion session, we probably have about 20 or 30 minutes. I invite all colleagues to share their thoughts. You can stand up and speak directly so we can exchange with the three speakers of the reports, which would be better. Please go ahead. Yes, please. Good morning, respected professors, chairs, and colleagues. I am Dr. Tung from the University Medical Center. As Dr. Dung mentioned, listening to Dr. Tai's CP presentation was truly fascinating, and there are many applications. This leads to some questions I have regarding clinical practice. First, regarding lung cancer surgery patients, we have two flowcharts from the ATS and ESTs, where the recommended timing for performing CP differs. I wonder if Dr. Tai could share more about why this difference exists, and how these two approaches differ in clinical practice. Secondly, besides lung cancer, we also have other conditions such as post-tuberculosis lung diseases, as in Dr. Tai's master's thesis, like bronchial stenosis, bronchiectasis, and pulmonary fungal balls. How can we apply CP to assess patients with non-cancerous lung diseases before resection or thoracic surgery? That is all for my questions. Yes, I would like to answer directly, Dr. Dung. Thank you for the questions. They are quite difficult, and Dr. Tai fears he may not be able to answer all of them. First, regarding the CP protocols, in different countries, it is heavily considered due to the very high cost, so each guideline offers a different level. For example, in the US, it is too expensive, so in almost all guidelines, CP is the last resort and is very rarely used because it is so costly. Over in Europe, it might be a little more open, so, generally speaking, it depends on the cost. Currently, with the situation in Vietnam, CPET prices range from about 2 million to 25 million, which isn't too expensive and can be done right away. Once the patient is indicated in the morning, they can be finished in 1 or 2 hours. Therefore, its accessibility and feasibility are completely achievable within our context in Vietnam. You could look into it, but according to Dr. Tai, it is more accessible compared to the guidelines. Second is post-TB lung disease. Honestly, during my master's thesis, the professors gave really intense feedback because global guidelines on CB currently focus only on lung cancer. So, we are forcing lung cancer guidelines onto post-TB sequelae and other conditions, like pulmonary aspergilloma or bronchiectasis, which the professors said is inappropriate and incorrect. But in reality, there are no guidelines for that in the world yet. Actually, in research, the only thing agreed upon in all articles and guidelines is the VO2 max, thresholds, or cutoffs. Meaning, no matter how different the approaches are, almost all studies show a consensus that a preoperative VO2 max above 20 milliliters per kilogram yields a very good surgical prognosis. Before surgery. Yeah. That is just the preoperative cutoff. But the postoperative cutoff is still highly debated. Usually, for a minimum level, after everything is resected, it should remain above 10. That's correct. We have to calculate it postoperatively, but generally speaking, regarding the current calculation method after surgery, why? Because the best way to calculate it is based on ventilation perfusion scanning. That is the only way to calculate it accurately, because when counting segments, we don't know which segment has high ventilation and which one has low ventilation. For example, with COPD, one side has lung cancer, while the other side has emphysema. Therefore, the ventilation and gas exchange roles of each segment are not the same. So, the most accurate method is to use a ventilation perfusion scan. But in Vietnam, we don't do that. That's right, exactly. So, for conditions like tuberculosis sequelae, bronchiectasis, and so on, currently, we mostly only use preoperative scans. We understand that high VO2 max indicates that the person's physical condition or cardiopulmonary health is strong enough to survive the surgery. That is a general way to understand it. It's similar to the ASA score in pre-anesthesia. Meaning, CPET is an objective measurement to demonstrate that their physical condition is strong enough to survive the surgery. Yeah. Currently, the formula for calculating postoperative function based on segment counting is the only method available. Yes, that is correct. That's the only one.
Thank you. Thank you, Master Tai. We see that it opens up more possibilities, that is, another method, but it is relatively complex. You all know that nowadays, to assess lung segments, techniques regarding dynamic CT scans are being developed. Pulmonary. To directly evaluate lung function. However, that is still something we are progressing towards. That is less invasive than having to exercise for this test. But this test assesses both the lungs and the heart. Both lungs and heart, right? So it certainly has its advantages. I welcome comments and questions from the doctors, especially our younger doctors in clinical practice. Do you have any questions or comments for Dr. Lan? Because I was planning to ask Dr. Lan myself. Go ahead and ask. Actually, I just have a quick question, because Bob, my hospital already has CPET machines, mostly used in the cardiology department, and through Dr. Tai's presentation, I found it very interesting and it opened up many new perspectives. We are also just starting to implement it in the respiratory center, whereas you have already proven it for 5 years, right? And you have implemented it in 3 units, so you have 3 machines, is that right? And Dr. Long wanted to ask, for example, Dr. Tai mentioned that CPET is widely applied. Because when implementing a technique, the biggest fear besides patient preparation and assessment is whether we have a patient source. So through Dr. Tai's report, it seems the patient source is very large, right? For instance, Dr. Tai said there is a recommendation for sports facilities to buy this machine to use for all patients, all athletes, right? Because I see that athletes coming to Dr. Tai for measurement, do they need to be screened first? Or do you do it for every patient, every case that participates in heavy sports activities? Or do you just do it for everyone? Yes.
Yes, thank you for the question, Ms. Lan. Our group helped write the upcoming clinical guidelines to be released soon. In those guidelines, my CPET protocol has very detailed indications for each specific group: respiratory, cardiovascular, metabolic, athletes, preoperative rehabilitation, so there are many. Regarding sports medicine specifically, there are many aspects, but currently we base it on the ACSM, the American College of Sports Medicine, which uses 3 questions to screen and assess whether a person has been exercising in the last 3 months. People who exercise regularly usually have a lower risk. Second, do they have any symptoms while exercising? And third, do they have any underlying cardiovascular, pulmonary, renal, or metabolic diseases? So, if this person does not have any risk factor from these 3 questions, their probability of needing a CPET is the lowest, right? They don't even need a screening exam before exercising. But if they have one of these 3, we usually have to do a risk stratification, and depending on their upcoming goals. If they set a goal of high-intensity competition, then these people should definitely have a CPET. In normal cases, the screening guideline we are currently drafting to support those in sports medicine, actually, incorporating an electrocardiogram is already a turning point. Meaning, if everyone, for example, running a marathon, gets an electrocardiogram, that is already good. Then, higher up is an echocardiogram, and even higher is a CPET. So there are steps like that, yes.
Well, thank you, Master Tai. Do you have any questions? Please stand up. Don't be shy. Everyone here knows each other. We're familiar now.
Any questions? Oh, it's all clear, isn't it? Now I have an important question to ask Dr. Phuong Lan. You had a slide stating that in the following cases, we should quickly switch patients to triple therapy because it is effective. Could you explain in detail how you apply this in clinical practice? That's a very good question from Associate Professor Dung regarding which cases we either start with ICS LABA, LAMA or switch from double to triple therapy. So, what do we see? Those transitions involve switching from ICS LABA to triple therapy, or from LABA to triple therapy. So, what do we see? If switching from ICS LABA, it already contains ICS, correct? Moving up to triple therapy, ICS LABA, LAMA, means adding LAMA. We know LAMA is used to manage symptoms. Therefore, in cases where we use ICS LABA but symptoms persist, we move up to ICS LABA, LAMA, right? The second group involves switching from LAMA to ICS LABA, LAMA. We see that switching from long-acting bronchodilators to triple therapy means adding ICS, so what does that imply? What is the purpose of adding ICS? The main goal is to manage exacerbations. However, when combined, it is found to resolve both exacerbations and symptoms simultaneously. So, if we are using LAMA but the patient still has many exacerbations, it should be triple therapy. ICS, LABA, LAMA. When do we use it from the very beginning? For a patient coming to us, as I mentioned in the presentation, treating early helps reduce exacerbations and significantly lowers mortality compared to starting late. So, in which cases can we start immediately with ICS, LABA, LAMA? The GOLD guidelines clearly explain this in the initial guidance, right? Cases in Group E, meaning many exacerbations, must use ICS, correct? And the patient is. If the foundation is LABA, in those cases, we need to use it right from the start. And that is, for cases with elevated blood eosinophils. In clinical practice, we see that for patients who have asthma, patients with chronic diseases. Why? Because the patient has clear symptoms, a history of exposure, dyspnea, and pulmonary function testing shows severe obstruction, along with nasal allergies, food allergies, and previous asthma attacks. In those cases, we see that ICS is necessary, and with severe airway obstruction, we must treat it with LABA, LAMA, which I find to be the best application in clinical practice. That is, patients with chronic obstructive pulmonary disease and bronchial asthma overlapping, correct?
Yes, thank you for asking.
Yes, I would like to ask the doctor. Asking Dr. Tai, in cases of evaluation with cardiology, such as stress echocardiography, cardiologists are very afraid of cases involving acute myocardial infarction requiring intervention. So, regarding CPET, when performing such cardiopulmonary exercise testing, is the risk that high? And before performing a CPET on a patient, do we need to conduct a thorough examination of their cardiovascular history, or does the CPET doctor need an opinion from cardiology? If there is an abnormal EKG or a history of cardiovascular disease, such as coronary artery disease, I am done.
Yes, thank you. This was exactly what I was most afraid of when I first started implementing this, because in the group, we had a cardiologist, but initially, when the pulmonologist did it, a cardiologist had to be present. 2 doctors stood together for one case, and then 2 or 3 years later, when we were more confident, we started working alone. However, the probability of complications for this is actually quite low. In the general population, it is only 1 in 10,000 cases. For a high-risk population in a frontline hospital like the University Medical Center, it is about 1 in 600 or 700 cases. So, for CPET, we follow the Mayo Clinic screening protocol, doing an echocardiogram, ECG, and spirometry before every session. If these 3 are stable and all underlying conditions are checked, we proceed with CPET. If there are issues, we will postpone or do CPET later. Yes, that's it. Also, I'd like to introduce how CPET is superior to a treadmill stress ECG. Actually, CPET includes an ECG within it. So, if we see signs of myocardial ischemia on the ECG, we will see it on CPET too. But CPET provides many other indices that detect changes earlier than a standard ECG. For example, the pulse oxygen consumption reflects ischemia in the small arteries. This means CPET can detect those signs earlier, which a treadmill ECG might miss.
Yes.
Thank you, Tai. This is basically a form of stress ECG. The risks are similar. The only thing is, it's more intense, because we exert more effort than a treadmill stress test. So, we just have to be careful. To say there are no risks is impossible because we are doing exercise testing. Next, do you have any questions? I'd like to clarify something for you with Dr. Phuong Lan. Dr. Phuong Lan presented 4 indications suggesting that switching to triple therapy within the first month is more effective, and listed 4 indications like frequent exacerbations, severe dyspnea, poor FEV1 response, rapid decline, and so on. However, I want to ask Dr. Phuong Lan, for clinical practice, why didn't you consider which patients should be considered for using an ICD? For example, Gold has stated that for cases of recurrent pneumonia, cases with blood eosinophils below 100, or patients with a history of pulmonary tuberculosis, we should consider this. Considering means that perhaps we might not need to use ICS. So, what then? Yes, a very good question from Associate Professor Dung. Dr. Lan also had a previous slide discussing when we prioritize using ICS, when we should use it, and when we should not use ICS, right? So, Dr. Lan discussed in that slide what cases we should use it for. And when our patients are in those groups where we should use it, but they have contraindications for ICS use, we will have to weigh the benefits and risks, right? For example, if a patient has asthma, and what? Meaning there is an overlap between asthma and COPD, but this patient frequently gets pneumonia, or this patient has a history of pulmonary tuberculosis and now the patient's lungs have many cavities. So, how will we handle such patients? Well, we need a comprehensive evaluation, right? We look at the severity of the patient's asthma, secondly, what the lung damage looks like on the patient's CT scan, whether it's extensive or minimal, and thirdly, we look at what? The severity of the exacerbations to evaluate if we use ICS for this patient compared to the risks if we do not use it, which is worse, so we can weigh the options. However, there are some considerations. For example, we know that as in Associate Professor Dung's report, we also saw what? When using ICS, there are certain types of ICS where the rate of infection will be lower, reducing the rate of pneumonia as well as respiratory tract infections. We can prioritize using inhaled corticosteroids with fewer side effects, if we find that the patient absolutely cannot avoid using them, right? So, in summary, we need to assess the benefits and risks of adding ICS to the treatment regimen for a chronic obstructive pulmonary disease patient. Yes.
Thank you for that clarification, everyone. However, there is another point I would like to ask Ms. Hong Lan on your behalf. Now that the triple therapy is effective. Yes, it is effective. I have used it for half a year and the patient is relatively stable. Is there any opportunity for me to step down to dual therapy? Because triple therapy is too expensive. I want to step down to dual therapy to save money for the patient. Is there any chance we can step down to dual therapy for the patient?
Yes. Professor Dung's question is very good, and I have been asked this by many colleagues. So, what do we see? For asthma, we know there is stepping down, right? And there are very clear guidelines from GINA. But for chronic obstructive pulmonary disease, do we step down? We know that COPD is different from asthma. Asthma develops in a sinusoidal pattern, meaning it gets heavy sometimes and light others, and the patient's baseline can still be very good. However, COPD is not like that. It follows a downward spiral, meaning it only gets worse over time. Therefore, what? When we have found a suitable treatment regimen that keeps the patient stable, we must try to maintain that treatment. Because we know that with that treatment, the patient still does not return to normal and is still ill, which is why we do not de-escalate for COPD patients. However, we can assess the ICS, the benefits of ICS, meaning we only reduce the medication if side effects are too severe, but we do not step down. Yes.
Thank you. The answer clearly explained the issues regarding the use of triple therapy in the effective management of COPD patients. Dr. Phuong Lan's answer also concludes this session of ours. We hope and are very grateful that you are all here in large numbers until the very end. And it has also provided very useful insights for all of our clinical practices. And since the time is up, we would like to declare this session closed so we can move on to the next session, and invite you to continue sitting and attending the new, very interesting session. Thank you. Yeah.